Good morning, everyone, and welcome to the Public Safety Solutions for Substance Use Disorder ECHO. My name is Julio Sotorblanco, and I will be the facilitator for today's session. This ECHO is brought to you by the Center for Substance Use Training and Telementoring, also known as CSAT, by Be Well, Texas, in collaboration with the UT Health San Antonio ECHO program. A few housekeeping items before we begin. We have live closed captioning available for today's session. If you would like to view closed captions for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. If you're having trouble accessing captions, please chat Echo IT Taylor. Please, to help us with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We encourage joining by video and using the chat and/or raise your hand feature to pose questions or share perspectives throughout the session. If you are having connection issues, please privately chat UT Echo IT for any assistance. As a note, these sessions are being recorded and will be shared on our website. Therefore, to ensure privacy, no personal health information is allowed at any point during the session. This includes client and patient names, addresses, birth dates, or any other identifiable information. At the end of the session, the ECHO team will send out a post-session survey link. We kindly ask you to complete it as it provides us feedback on how to refine these sessions to better address your priorities. We're approved for CEs for paramedics and any public safety professionals with a behavioral health degree, such as social work or counseling credential. Finally, ECHO is an all-teach, all-learn environment, and we encourage everyone to participate in the conversation and raise questions. So with that, I'd love to move on to some team introductions. First up, we have Jeremiah Golka.
Hi, everyone. I'm Jeremiah Golka. I'm the Executive Director of the SHIELD Training Initiative. We provide occupational safety and health trainings for police, other first responders, and criminal justice professionals on their work related to drug-related encounters and the overdose crisis. And that's my microwave beeping in the back as I'm going to have some lunch.
Great. We also have with us Brendan Del Pozo.
Hi, my name is Brendan Del Pozo. It's good to see everyone. I am a professor of medicine and public health at Brown University. Prior to that, I was a police officer for 23 years, 19 in the New York City Police Department, and 4 years as the chief of police of Burlington, Vermont.
And also with us, we have Cynthia Mendiola.
Good morning. Welcome, everyone. Excited about today's participation and lecture. My name is Cynthia Mendiola. I am a retired federal probation officer. I also am a trainer and a coach in core correctional interventions, and I'm currently working in immigrant safety. Thank you.
Thank you. Our didactic presenter for today is Lisa Zottarelli. Please let me know if I said that correctly.
Yes, that's fine. So I'm Lisa Zottarelli. I'm at the University of Tennessee, Knoxville. I have a PhD in sociology, a master's in public health, and I'll introduce myself a little bit more with the presentation.
Great. And our case presenter for today is Edward Lopez.
Hello, my name is Edward Lopez. I'm a United States probation officer here in San Antonio, Texas. I've been working in the field of criminal corrections now for 24 years.
Great. Thank you all so much for being here today. With that, let's go ahead and get started with our didactic presentation. Dr. Zottarelli, once you share your slides, feel free to take it away.
Okay, great. Thank you. Share and let me come back here. Okay, can I start, Julio? Okay. So today's presentation is titled Heatwaves and Health Gaps, EMS Data in Warming Cities. As I mentioned a moment ago, I have a PhD in sociology and a master's in public health. I am currently on faculty at the University of Tennessee, Knoxville, where I work in the College of Social Work. My research focuses on the social context and consequences of disasters in extreme weather. And I'm particularly interested in social vulnerability and morbidity within these environments. I have a long-standing interest in EMS and first responders. Professionally, I worked as a clerk and a tech in an emergency room hospital ER for 9 years as I put myself through my undergraduate. I've also conducted research related to law enforcement, family to work, and work to family conflict after a number of hurricanes. And I'm the proud mother of a firefighter. So I come to an interest in first responders and in pre-hospital care in a number of different ways. So disclosures, I'm sure you have these disclosures for every presentation, but I do feel obligated to cover them. I'm sorry, my screen is a little in my way. Oops. I've lost my. Okay, so disclosure, all speakers and all members of the planning committee have no relevant financial relationship with a commercial interest to disclose, and the views and opinions expressed by the participants and the speakers attending the ECHO sessions are solely their opinion and do not reflect the official position or policy of UT Health San Antonio. So by the end of this brief presentation, you will be able to identify patterns in EMS call volume during extreme heat events in San Antonio, Texas, explain how social vulnerability, specifically poverty, age, neighborhood factors, etc., intersect with environmental conditions to influence EMS demand, and discuss implications of using environmental data for improving emergency preparedness, response planning, and equitable resource allocation. So I want to start by talking about EMS and community morbidity. So EMS can provide practical and real-time surveillance that reflects acute events and broader public health issues. And for EMS and when we think about EMS and the community, there's really 4 ways we can think about how EMS does this. First is a direct link to acute health events. High EMS call volume often signals increased rates of acute illnesses or injuries, such as cardiac arrest, strokes, respiratory issues, overdoses, or trauma. And spikes in specific types of calls, such as breathing difficulties or flu-like symptoms, can indicate outbreaks or public health emergencies. For example, we will see increases in breathing difficulties associated with wildland fire as the smoke and particulate matter spreads over populated areas, or we see this with seasonal flu and COVID outbreaks. EMS also reflects the community chronic disease burden. Frequent EMS use can reflect poorly managed chronic diseases like diabetes, heart failure, or COPD, and these patients often call EMS when their conditions decompensate. Increases in non-emergency EMS calls may reflect a lack of access to primary care, leading to worsened chronic illnesses and preventable emergencies. We can also think about the acute health events and chronic disease burden being linked because vulnerability created through chronic disease places people at an increased risk. For example, certain conditions and medications may result in compromised immunity to communicable diseases. Some medications and conditions may put people at greater risk of adverse health outcomes due to heat. And so the first and the second bullet points are linked. The socioeconomic and environmental stressors are also important. So we think about communities with high EMS call volumes often experience higher levels of poverty, violence, substance abuse, and housing instability, all of which are linked to increased morbidity. And EMS use may increase during extreme weather. We see this in hot waves or heat waves. We see this in cold snaps, especially among vulnerable populations such as the elderly, homeless, and chronically ill. And of course, socioeconomic conditions and environmental stressors are linked to the first 2 bullet points. And finally, there are temporal and spatial patterns that show us trends over time or differences between neighborhoods that can reveal health disparities and guide public health interventions. For example, repeated EMS calls from certain areas might indicate environmental hazards, inadequate health education, or unmet health needs. So EMS call volume can function as a measure of morbidity in that it is a practical real-time surveillance tool that reflects both acute and broader public health issues. Health departments and planners can use this to identify trends, allocate resources, and target interventions. Now, heat is a complex hazard. It's considered a complex hazard because the impacts are wide-ranging, interrelated, and influenced by multiple factors, including environmental, social, economic, and infrastructure elements. When we think about the classic definition of a disaster, we see infrastructure disruption and increased morbidity and mortality occurring concurrently. With extreme heat, and indeed even just heat, we see that increases in morbidity and mortality, especially among vulnerable populations, precedes infrastructure disruption. And our response to extreme weather has often been built on the definition of disasters or the assumptions that we attach to disaster, and not to the kind of hazard we see with heat. There are some additional reasons why heat is a complex hazard. One, we have climate and urban environments where urban heat islands can amplify temperatures. Humidity interacts with humidity interacts with temperatures to affect human health more severely. So we often think of, when we think of creating policies and plans around heat, we often include the heat index. Air pollution often worsens during heat waves and can compound the heat effects of heat. Vulnerable populations. Not everyone is equally affected by heat, we have the elderly, children, outdoor workers, workers who work in indoor, unair-conditioned spaces, low-income groups, pregnant women, people who are homeless, people living in lower socioeconomic conditions who cannot afford or do not have access to air conditioning, people with substance use disorders, and people with pre-existing conditions, to name a few, are at higher risk during extreme heat events. Access to cooling, such as air conditioning and other protective measures, such as access to healthcare, can greatly influence health outcomes. And we have health and economic and infrastructure impacts. These can either promote or inhibit exposure to extreme heat and some of the other issues around extreme heat. In addition, well, a few minutes ago, I mentioned the fact that with heat, the infrastructure disruption often occurs after we start to see morbidity and mortality effects within the population. Heat does create strains on infrastructure, and we can have events such as power outages, transportation delays, failures of cooling systems, and stresses on healthcare systems. Heat can also reduce productivity, particularly in sectors like agriculture and construction. So extreme heat has this slow onset cumulative effect. And unlike sudden hazards such as tornadoes, extreme heat often builds over time and can go unrecognized until it's critical. Successive hot days, often referred to as heat waves, can have cumulative health effects, and we see in the literature in terms of time lags, where we examine health outcomes during and after heat waves. So extreme heat is challenging to predict and communicate. The thresholds for heat alerts will vary by region and population, and public awareness may be low. Warnings may not always lead to action, especially when we have a cultural context where the location has a narrative about heat that may make people less likely to respond in protective ways. So San Antonio, as you know, is located in South Central Texas and experiences long, hot summers with frequent temperatures exceeding 100 degrees Fahrenheit. And with the changing patterns in climate, the city is seeing more intense and prolonged heat waves. What we have at the slide on the figure on the graph on the left is what we can expect to see based on previous cycles of information about days over 100, what we can expect to see as we move toward the middle and end of the century, which is an increasing number of days over 100 degrees Fahrenheit in both conservative models as well as models that present worst case scenarios for trajectories of temperature increases. We're also seeing the nighttime temperatures increasing. And nighttime temperatures are particularly important because they offer an opportunity for people to get a break from the heat and to cool down. And so from 1970, I need to be able to see the screen. 1970 to 2018, we saw an increase in overnight average low temperatures. Now, the reason why this also becomes important is that many of the ways we think about extreme heat events require that we compare a temperature or heat index to the norm. And San Antonio climate norms have been changing over the past 30, 40 years. So we see that the National Weather Service updates climate normals every decade, providing a 30-year average of weather variables such as temperature and precipitation. And these updates reflect changes in climate patterns and serve as benchmarks for assessing current conditions. So while the average annual temperature, and this is both highs and lows across the entire 12-month time period per year, between 1981 and 2010 was 71.5 degrees Fahrenheit. Between 1991 and 2020, it rose to 72.5 degrees Fahrenheit. We see this for July highs between July daytime high temperatures between 1981 and 2010, the average was around 96 degrees Fahrenheit. And from 1991 to 2020, that average is now 97 degrees Fahrenheit. So we're seeing this slight uptick, but that slight uptick then changes what extreme looks like if we're basing extremes off the distribution of the normal extreme high temperatures. We are also seeing increases in annual precipitation by about 1 inch in those same time periods. So what we're seeing with these normal baselines as they start to shift upwards is that we have a warmer baseline. An increase in temperature normals mean that what was once considered above normal is now going to be closer to average or normal, potentially leading to or changing the way we think about the frequency of the heat advisories, especially if we're relying on difference from the mean. It has implications for urban planning as we talk about shifts in urban development, heat mitigation strategies, green spaces, and reflective materials. And it also means that we have to pay attention to how these norms are captured in policy and in practice as we're beginning to think about extreme heat events. So Bexar County heat-related illnesses have gone up. They've increased over time from 2018 to 2023. And while we do see an increase in heat-related illness, including dehydration, heat cramps, heat exhaustion, and heat stroke, yet many heat and heat-related illnesses are poorly captured and are likely underreported, especially when heat is an underlying factor influencing an event. For example, in pregnancy, we may see dehydration and preterm labor without documentation of the environmental conditions and exposures prior to the dehydration. And so we don't necessarily capture extreme heat or how heat contributes to these events or to these factors. And there have been efforts to build case definitions for better surveillance around heat-related illnesses, but a lot more work needs to be done in this area. So my team and I worked on a project looking at San Antonio EMS and heat. And we conducted a number of studies looking at heat in a few different ways, considering both social vulnerability and air pollution in terms of PM 2.5 over the course of 4 constrained summers. And a constrained summer is simply the hottest time of the year from May 1st to September 30th. The EMS, for all of these studies, we had EMS data by zip code from the San Antonio Fire Department. We used heat data in different ways. First, we used the heat index, looking simply at the heat index and looking for increases in heat index relative to EMS use. We also considered heat waves. And I guess, well, let me tell you about the heat index. The heat index is a combination of temperature data and humidity data. It's the feels like temperature. And higher heat indexes, that kind of wet, swampy heat that we get in Houston and in San Antonio, is very different from the dry desert heat that they get in Phoenix and other areas of the country. And so, and heat indexes are important because we do see physical response to the heat index and adverse health outcomes happening at lower temperatures with higher humidity. So the heat index is important. Heat waves, lots of different definitions. The WHO uses a definition of 2 consecutive days of temperatures above normal. And so there are some definitions where they use 3 consecutive days of temperatures above normal. In our study, we did use the WHO 2 consecutive days above normal. And then heat index thresholds. And that we are looking at thresholds of heat and humidity, the heat index, at 90 degrees Fahrenheit, 95 degrees Fahrenheit, and 100 degrees Fahrenheit. And we chose those because of San Antonio's heat plan, using heat indexes, the importance of the 90-degree threshold in a city like San Antonio, where there are adverse health outcomes at that level. But it's also a very common temperature in a very common heat index in San Antonio. And then the 95 and the 100 thresholds. The social vulnerability data comes from the US Census, where the census data ranks every census tract in the United States for factors that affect a community's ability to prepare for, respond to, and recover from hazards. It's assigned a score from 0 to 1. The higher the value, the greater the social vulnerability. Because we had EMS data by zip code and social vulnerability by census tract, we used a HUD formula to convert from census tract to zip code data. Within the social vulnerability variables, there's 4 major themes and really 15 variables within there. And these are socioeconomic status, household composition and disability, minority status and language, and housing type and transportation. And while there are other measures of vulnerability that we could have selected, we use the CDC Social Vulnerability Index because of its national coverage, which means that we could replicate studies in other parts of the country if we chose to. It also was specifically designed for disaster work and disaster response, with community and local government response considered in the development of the index. And so we selected that over some of the other options we had with regard to social vulnerability. For the particulate matter data, which comes up in just one paper, we included that because San Antonio went into non-attainment by EPA standards during this time period between 2015 and 2018. And so we were in very early non-attainment, and we wanted to capture some of that effect in our look at the heat index thresholds for the city of San Antonio and its outcome on and its impact on EMS use. PM 2.5 stands for particulate matter, and this is very small particulate matter. And these tiny particles are a major component of air pollution and are considered especially harmful to human health. They can be made up of dust, soot, smoke, organic chemicals, metals, sulfates, nitrates, vehicle exhaust, industrial emissions, construction sites, wildfires, power plants, and residential wood burning. So they come from many sources. Often we think about one of the prime contributors is vehicle exhaust. And PM 2.5 is particularly important to examine because the particles are so small that they bypass the body's natural defenses, like the nose hair and the mucus, and they travel deep into the lung, where they can even enter the bloodstream. They cause or worsen respiratory and cardiovascular problems such as asthma, heart attacks, strokes, and lung cancer. And they result in premature death, especially in the elderly and those with existing health conditions. Our PM 2.5 data comes from EPA measures in the Bexar County. Okay, so we did what I'm talking about today are really the combination of 4 studies that we did. And the objective of each one was really just to start to tease apart our understanding of heat and EMS, considering the social vulnerability present in San Antonio, and in one study bringing in, taking out the social vulnerability and bringing in pollution. So in our first study, we examined the effects of daily high heat indices and community level social vulnerability on EMS on-scene responses in San Antonio. And we found that both high heat, the higher the heat index and the greater the social vulnerability independently increased EMS on-scene responses. And the interaction between the two further elevated EMS demand, particularly among socially vulnerable communities. What was important with this study is that social vulnerability was actually the stronger predictor. The heat effect, and we'll see this in all of the studies, heat doesn't necessarily have a huge effect size. It's statistically significant, but not necessarily a huge effect size. But we do think that if we were to have more robust EMS data, we would be able to work further to better understand that. We in one of the other papers, we looked at heat waves and air pollution, PM 2.5 air pollution. In this case, it was the combined effect of heat wave and this fine particulate matter on EMS calls. Both heat waves and elevated 2.5 independently increased EMS call volumes, and the interaction further amplified this. With San Antonio being in and at this time period, having been recently in non-attainment, this is not even, we certainly know that the air pollution was likely to get worse. I've not looked at the current data to see where air pollution is with regard to San Antonio, but it was likely to get worse. And we were really seeing effects even at that initial designation as non-attainment. And one of the important, and the other piece that I want to highlight that I think is important from these 4 articles is the study where we looked at the heat thresholds. And that is in the heat. I'm sorry. I lost my notes. Where we're looking at heat thresholds, the heat threshold set at 90 degree heat index, 95 degree heat index, and 100 degree heat index. And we found statistically significant relationships with EMS utilization at the 90 and 95, but not the 100. And that opened up a very interesting opportunity to think about the way in which we think about extreme heat events and how those are messaged, and what may be some factors that are influencing EMS call volume to increase at the 2 lower thresholds and not at that higher threshold. And again, further data would allow us to go deeper into that analysis to be able to understand more about why 90 and 95 and not 100 degree heat index. So the future for directions for our research is to continue to look at this combination of EMS heat, social vulnerability, and bringing in pollution data to understand how vulnerability starts to interact with heat and interact with pollution to increase or to change EMS call volume. And we're particularly, in my research team, particularly interested in this issue of social vulnerability, given the fact that so many different populations are vulnerable to heat, and that vulnerability to heat can be transient. It's not necessarily a static condition. And so when we think about we think about vulnerability to heat. Right now, some of my work is looking at pregnancy and heat. And pregnancy, of course, is temporary, but the vulnerability that emerges during pregnancy to heat is significant for both the person who is pregnant as well as the child. And so we are focusing in that area. And there's some additional some other researchers who are also bringing in pollution to this, to wanting to understand the vulnerability around pregnancy and heat. Given this group's interest on people with substance use disorders, there's a growing body of research that is looking specifically at that population, both as the population maybe have increased susceptibility to heat, but that even without the substance use disorder, even temporary use could inhibit and or greater enhance one's vulnerability to heat. And so that is something worth exploring as well. So I will open it up to questions or comments.
Great. Thank you, Dr. Zottarelli, for that wonderful presentation. So at this time, we would like to open up the floor to the learning community and our hub if they have any questions for Dr. Zottarelli and their team, and for Dr. Zottarelli.
I have a question if no one else does yet. I didn't see it. Someone else have one? If not, thanks, Lisa, a lot for that. That was really, really interesting. Before I ask my question, I saw Lindsay in our ECHO group asked what non-attainment means, and that's about. Do you want to answer that?
Non-attainment is an EPA designation that has to do with air quality, and when you go into non-attainment, you no longer it's considered an adverse air quality measure or adverse air quality indicator. And Dr. Gulka, did you want to say some more about that? It sounded like.
Oh no, I think that probably covers it. But I have a question, which is to ask whether, and the folks who are here to see if any of the things that Dr. Zottarelli talked about are kind of prompting thoughts or things that you all are seeing among the folks that you're serving at all. I have a couple directed questions, but I'm just curious to know if the folks are seeing connections between heat or pollution and the folks that they're serving.
So I was going to bring up that during the pandemic, we had higher rates during the winter and the summer because people were inside more. I trying to get Chat GPT to tell me a scientific term. It's saying seasonal forcing, but basically just that Texas specifically or any hot area has two seasons where people are indoors more. Mm-hmm. So that may be why when we had the 100-degree temp, there were more alerts ahead of time. People knew ahead of time. They would stay in the buses longer. They would go to the libraries. They would go to the mall, whatever it was, and be protected from the weather, even just with a 5-degree mark. I'm sure there's a scientific term more than what I'm telling you right now, but that's what came to mind when you were speaking.
Mm-hmm. Yeah, we felt that there was likely just that interest and willingness to stay out of the 100-degree heat, where 90 being perceived as pretty normal in Texas, in San Antonio, didn't necessarily prompt that same kind of response, which exposed people to the temperature. And having lived in San Antonio and in Austin, it's hard to avoid 90 degrees.
Are other folks seeing stuff, seeing impacts? I know Lindsay mentioned in the chat that there's an increase in meth. It's definitely connected to heat issues.
Mhm.
Does anyone want to come on and share?
Oh, I can just tell you from personal experience that like if you're, using any stimulants, it makes the heat much worse.
The impacts on your body.
Yeah. And I've seen people go into like heat exhaustion and heat stroke fairly quickly.
Right. I think that's what the literature is saying, is that stimulants are tied to, particularly stimulants are tied to like an acceleration of heat impacts upon people's bodies.
Mhm.
It's too bad Dr. Montez wasn't able to join us today, because maybe he could kind of talk us through this. I don't know if anyone else wants to talk about the physiology of it. I know I cannot. Also curious to know if you all are seeing any specific connections with unhoused communities.
I think it's important to note that, especially from the research that we have on this presentation, is that the heat indexes are even much higher in these last few years, which you're showing us also through the research. And so some of the vulnerable individuals that we deal with day to day that are using and the different substances that they're using, I think that it exacerbates their medical conditions as well, as they're using and in combination with the heat, and especially these higher heat indexes that we're getting nowadays. And that's what I've noticed more also.
Great, really great points of discussion. I think we have just a moment more for one more question. Sandra, I saw that you posted a question in the chat. Would you like to unmute and ask Dr. Zottarelli your question? If not, I can just go ahead and ask it. So she said that Dr. Esteban Ochoa is placing air quality meters in some community homes here in San Antonio. She's just learning what the colors indicate. Are you researching any data from some of these types of devices?
I haven't researched any data from internal air quality meters, although what I have seen in this literature is that sometimes air quality inside the home is actually more detrimental to individuals, particularly those that already have underlying respiratory conditions, than even the outside air quality. And so I'm excited. I wrote their name down, and I'm gonna follow up to see what work they're doing, because I'd like to read that.
Definitely interesting. So with that, thank you again, Dr. Zottarelli, for this great presentation. We'll go ahead and move on to some quick announcements.
Okay.
Taylor, if you could pull that up.
Mhm.
Thank you so much. So to claim your CEU credits, you must complete the post-session survey in the chat or by email sent after the session. Complete the post-session survey and select yes on the question, are you applying for CEU credits today for today's ECHO session? Your certificate of completion will be sent to you 2 to 3 weeks after the session date. If you have any questions, email bewelltexas@utesca.edu. Next slide, please. Do you have a difficult case that you or your team have encountered? CSAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from your hub of experts and broader learning community. There is no need to prepare a formal presentation. We will provide a case form to fill out to assist with your case presentation. Please email cstat@utesca.edu. Next slide, please. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorders needs and topics through our network of subject matter experts. To request technical assistance, please complete an online request form through the link in the chat, and we'll be pleased to help you. Next slide, please. And lastly, please join us next month for another Public Safety Solutions Echo on Thursday, June 12th at 11 a.m. Central Time. Thank you so much. Let's go ahead and move on to our case presentation today. Taylor, if you can bring up the case form. Edward, please walk us through the case.
All right. So I'll wait for the form to come up here real quick. So this particular person is on my caseload. I've had this person on supervision before. The person was revoked, came back, and we're starting to see the same patterns of behavior. In this case, this person submitted a UA that tested positive for methamphetamine or for amphetamines. I called the person denied it over the phone. I asked the person to come in to the office. During the office visit, I discussed the importance of honesty and tried to really build that rapport bridge to get this person to understand that if we need help, I'm here for that. The person eventually ended up admitting to using methamphetamine. One of the things I noticed in this particular person has really bad cognitions, and in our world, that means that this person's thinking patterns tends to reflect an ability to easily do negative behaviors. In this case, the using of methamphetamine. This person also has a tendency to hang around with negative influences. The first time this person was on supervision with me, I really was honing in on the cognitions portion of things that maybe this person needed. This time around, I kind of switched it up and started to try to make it more practical. So this particular sense, I used what we call a life skill. So I was teaching this person how to avoid trouble with others, which involves certain steps, thinking steps and action steps to be able to kind of give them a process to be able to get away from negative social behaviors. During the teaching of this particular skill, I connected what I've taught this person before, the cognitive model, how thoughts affect behavior, uh, how thoughts also affect your social networks. How we all think the people who you call your friends usually think alike, like the same things. So being able to recognize that if you're liking things that are negative, you tend to hang around people that are negative. So I want to kind of switch that thought pattern to more positive things, more goal oriented, in the sense that I want this person to really work towards more positive things as a goal to keep this person away from the negative influences. This person does live in a small community, and I don't know if those who have lived in a small community, everybody knows everybody in these places, and it's definitely difficult for some to stay away from the negative influences. And after the meeting, the person seemed very receptive. The person was very grateful that I was kind of trying to help the person and recognizing that some of these issues are coming back again. And this person uses the illegal drugs to kind of cope with stress. During the conversation, she was talking about the house that she was living in with her sisters kind of full. Her transportation's up and down when it comes to things, and this person just when those situations happen, that's the usual coping mechanism for this person. So trying to get this person to recognize that those coping mechanisms aren't going to be better or aren't going to be good for her long term, and trying to provide this person with better tools to work through situations. I picked this particular one because during the conversation, this person was bringing up people, like hanging around people. And I had recently taught this person another lesson, high risk people, places, and things. So everything I've taught this person before, I was really trying to put together to get the person to understand that everything is building on itself. And this particular skill of avoiding trouble with others is like a culmination of all the things I've been teaching this person up till now. So I'm focusing more on providing her with life skills to be able to get through certain situations, whether it's avoiding trouble with others like this one, stress management, learning how to say no. Like these are some skills that I've noticed that a lot of people that are on supervision really don't have. So I'm definitely now focusing more on that part of her supervision. Uh, and that's pretty much it for now. She is coming back later to review the homework, and I'm probably going to teach her one of the skills that I went forward with you, either learning how to say no or a stress management skill.
Thank you, Edward.
Yes.
I like that you were a little bit more in detail other than what we saw on the case form, which helps us kind of figure out where you're going with this person. I just wanted to clear a couple of things. The acronym for CNVC, is that Criminogenic Needs and Violence Curriculum? Is that a curriculum that you're using
Yes.
with this individual?
That
Okay.
is the curriculum that we use here in this office to assist us with behavior modification.
Okay, and that is also it also kind of helps to have a common language for yourself, the person you're working with, and the treatment
Mhm.
providers. Is that also helpful for the providers, the people that you send them, the individuals for treatment?
Yes, usually what will happen is when we staff cases, we'll talk about what we're helping with to kind of work with the treatment provider. The other thing we share with them is the risk assessment. So if there is any kind of, in this case, what we call elevated thinking style, which is some negative thinking patterns or a dynamic risk factor that seems to be glaring, those are things that we share with the treatment provider to kind of get them to see this is what we're doing on our end. What can you do on your end to kind of help with these? Because this is what I'm seeing when I'm doing home visits or when I'm talking to this person, because I'm probably seeing and talking to this person more than the treatment provider.
Awesome. So I guess what you're trying to say is that what the risk assessment that you use
Hmm.
and the PICS, which is called the Psychological Inventory on Criminal Thinking Styles. And
Correct.
so what comes out is this person's cognitions as number one, you're saying,
Correct.
maybe peers. And so
Yes.
those are some of the areas that you're targeting, and then you're sharing that assessment with the people that the person's receiving treatment from, correct?
Correct.
Awesome. Okay, so everybody's working together to kind of focus in the most major risk factors for this person, and you're starting to see that as you're out in the field and making visits and communicating with the person and your interactions. Is that what you're suggesting?
Yes. And the last conversation I had with this person, you're starting to see this person recognize, I did something wrong. Um, and providing her with that ability to be able to say, uh, how can we work together to keep this going? That rapport building is definitely very important in this particular process, especially since I've had this person before. I was really impressed with this person's ability to put that first revocation aside because sometimes when they come back out, they're kind of hard and like, well, you sent me to jail. This person was very, I messed up. I felt like I had something to work with. So when this person came out, I was able to kind of reconnect and build that bridge and say, look, yeah, you messed up the first time, but let's use those examples as a way to learn so that we don't make those same mistakes again.
Awesome. Thank you.
Mhm.
Any other individuals have some questions for Edward on his work with this person?
I think Crystal, you posted a question in the chat. Would you like to unmute and ask your question? I'll get to her in a moment. So I know, Jody, it looks like you had also posted something. Would you like to unmute and add any other?
I guess just kind of get her thinking where she could start making changes instead of having somebody tell her what to do. Is kind of get her to thinking um, how could she do something different to get into a healthier, successful lifestyle?
Yes, during the process of teaching, like this particular one, avoiding trouble with others, one of the steps is getting them to recognize that they're able to think and internally talk to themselves about what are my goals? Where do I want to be? Is this person or this relationship that I have right now going to help me get to these goals? So, I really, in my communication with people, do exactly what you're saying, Jody. I try to get people to think for themselves. I don't want to tell them what to do. I kind of want to show them, like, if you do these things, they'll help you make better decisions. And when you're making better decisions, you have a better tendency to not be in negative situations, finding yourself in high risk situations. But at the end of the day, one of the other thing that I also talk about a lot is accountability and responsibility. Is that, all this supervision work that I'm doing means nothing if you're not doing it, if you're not working it, if you're not using it. So I want to make sure that they take ownership of their supervision and have a working relationship with the person, in the sense that I want this person to recognize that I'm a help, but at the end of the day, they're going to have to put in the tools and the work to make these better decisions.
So I have a question, Edward.
Yes.
So you mentioned a couple of things that I thought were important, is that the person came out of, custody and went back to you. And of course, people in recovery, they go back and forth, and they have, they learn from some of the mistakes and some of the things that they did in the past, and they try to move forward. Do you consider working with this individual based on, as far as, like, for example, you said, well, we're going to work on maybe some cognitions, and these are some things I've noticed. What did you notice about how you think in the past and how you can change that, right? Do
Right.
you consider maybe, do you look at the stage of change? Where are these people in the process of change? Are they willing to accept, are they in pre-contemplation? Are they in contemplation? Do you consider those stages when you're working with these individuals?
Yes, and you kind of notice, and you've been here, the amount of people you have, you actually do kind of have to triage, right? Like this person in pre-contemplation, I'm putting in the effort here, but I'm not seeing a result. I need to shift that emphasis and work to someone who wants to put in the work. So yeah, you kind of see that. This particular person goes back from pre-contemplation to contemplation, depending on the situation. And I'm trying to get this person to recognize that for growth to happen, you need to always be thinking, how can I do better? Where am I at right now? You got to be cognizant of what's going on. And I think sometimes this particular person in particular, um, has a trouble with with the emotion side. She allows the emotions of a situation, whether it be a good emotion or a bad emotion, an emotion nonetheless, to kind of dictate what happens. And I'm trying to get her to see that through her cognitions. When she's hanging around people, it's not always cool to look cool, right? Sometimes it's better just to get away. But this particular person doesn't want to seem like she's not in the crowd, or she's not trying to break that understanding of a social network with this person has been a challenge. And again, I think that has more to do with the fact that it's a small town. It's everyone knows everybody, and I understand that as a variable. It's difficult to get away when you don't really go a lot of places, right? There's really not a lot of places to go. So that's definitely an environmental issue that I constantly have to deal with this person.
Thank you, Edward. That kind of gives you an insight on what you're having to deal with this individual. There's a lot of drivers for some particular things that are going on with this person. There's a lot of ineffective coping skills that have to kind of be replaced with effective coping skills, and so that habit is there, and that's really difficult from what I can see in your case. And the other thing that's really important is that this person's willing to make some changes, but it's really very slow in going.
It is, and the last time this person was on supervision, she was making great strides, that everything was going good, and then just that one hiccup, and it just, I mean, from one day to the next, it just fell apart, and she
Yep.
just couldn't cope. She just couldn't she couldn't figure out. She didn't see she didn't see the light at the end of the tunnel. All she saw was everything's falling apart. And she reverted back to what she always does when things fall apart, to
Was
cope.
that, I'm just curious, was that maybe resulting in committing crimes or
No,
behavior
straight
or?
use. I mean,
Okay.
she ended up losing her job, then she ended up losing a place to stay, and then I lost communication with her for a while. I mean, it just from one day to the next, it just collapsed.
Mhm.
By the time she was able to reach out to me, it was too late. I mean, months had passed by, and it was more than we could do on our end when it comes to accountability on my side, with my work. It was unfortunate because she was doing really well.
Thank you.
Mhm.
Great. Then I think it's one of the final things to pose, we can ask Crystal's question. So is there any RSPS or peer support or recovery coach involved with this specific individual?
Right now, she's in active treatment. So she has a counselor. She is at Camino Real, so they do have an aftercare uh, provider. As in, once they finish treatment, they have a peer coach. They connect them with somebody to kind of continue the process. Um, so yeah, they do have that. She's not there yet. She's still in active treatment. Um, so she's now, well, now that this has happened, she went from every other week to weekly now. So they're seeing her more.
Okay.
I'm talking to her more, whether it be either in person or on the phone. I'm trying to use all the technology that I have at my disposal to kind of just constantly keep in some kind of connection with her as a little reminder of, hey, I know things are tough, but let's work through this. Let's figure some stuff out. So, um, but when she finishes treatment, that's the next step. She will go to that, the peer support aftercare.
Sure. Sounds like there's like a lot of great support, and it sounds like you're putting in a lot of work for this patient. And that's great. We love the work that you do. Thank you so much for presenting this for us, Edward.
Thank
In
you.
the interest of time, let us move on to the case summary. Jeremiah, could you please give us a summary of recommendations for today?
Sure. So, it's uh, linking out all of today. I think we learned some interesting things today from Dr. Zottarelli. I was glad she could come and start queuing conversation along about the impacts of heat connected to EMS. And I know we try, there's this like this challenging link between you all see the things that affect you and your clients, the people you take care of and support, like on the daily life, within trying to connect it to the bigger picture as we understand how different things are impacting the community of people who use drugs that we care about, and we're trying to help. So, uh, building up this knowledge base is useful. This is something I know I'm just personally interested in, and as I noted in the chat, that the impacts on uh, how climate change and pollution are impacting people who use drugs is just starting. That research is just getting going. There's a few studies or a couple uh, systematic reviews of those. But whereas when you compare it to just health impacts overall, which has got a ton of attention, it's just really kind of getting it kind of late. So anyhow, I'm very curious to know what you see, what you've seen. If there's anything, you can raise it here, reach out to me directly if you want, ever. And we're trying to kind of push that along. And then within uh, the case, it's highlighting so many of the different issues of how to meet the probationers where they're at and how to help and how to get there and in time and provide services when you can, and how to uh, the sort of, I guess, dance that goes on with when people, if they've returned to use, they've, had a drug screening is tested positive, and then figuring out how to, kind of what to do with that in a way that is supportive and understanding, and not to harsh, and that seems to be always a challenge for our probation officers who are trying to bring the services that they're aware of within the constraints they're operating in. And so thank you, Edward, for presenting on that, Cynthia for your leadership in that field. And I think it's 1 o'clock, my time, noon yours.
Thank you all. Thank you so much, Jeremiah. And thank you all for joining today's Echo session. As a reminder, to earn continuing education credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email bwilltexas at bwilltexas@utesca.edu. And we look forward to seeing you at our next session on Thursday, May 8th at 11 a.m. Central Time. Have a great rest of your day, and thank you all so much for being here.